Hello, I'm Dr. Murtada. I want to make a demo for Izumo 3000 ultrasound machine with multi-purpose used for regional nerve block, for pain management, for fast technique, and musculoskeletal injection. This machine have animations, have software. This software contains all the steps of the regional block and pain management and musculoskeletal injection, also the vascular access by animation and demo inside this machine. Okay, now we start by the procedure, the top icon here. Just to base the procedure, we have Doppler basic, needle in plane, needle out of plane, organ examination, probe manipulation, and scanning condition. Start by the needle in plane. As you see, the basic of this machine will teach us or learn us how to use the probe in in a plane and out of plane. Just go to CE cards. Now we see for the introduction. In a plane, a probe needle. That's mean insert the needle under the probe in the long axis of the probe to reach the structure. As seen in this demo, we see the needle entry. This is an in-plane technique which usually used for the regional block. What mean by alignment? This is the alignment. Take your probe near to the probe to the near to the needle and out of needle. You see, you can visualize the end of the needle or the tip of the needle, but by alignment, you can visualize this is the wrong. This is the right. You should visualize the tip of the needle by alignment. That means the tip of the needle perpendicular to the sound wave coming from the probe. This is the alignment solution. This is the echogenic needle. This is non-echogenic needle. This is the different. This is non-echogenic needle. You will see the echogenic needle with the nano line. Angle of incidence. This is tip angle and shallow angle. This is the shallow angle. You see the reflection of the sound wave perpendicular return back to the piezoelectric material of the probe. While in steep angle, you see the perpendicular wave or reflection is coming from the probe, but when hit the needle, the reflection will go perpendicular, so you can't visualize the tip of the needle, just tactile sensation or tissue enhancement when you insert in the steep angle. See, it's very clear. Now return back to the needle in plane and out of plane. Workplace, this is the proper position. You should have coordination between your needle and machine. This is the right technique. This is the false. So the monitor should be in front of your eyes and coordinate with your hand and the probe. your eyes to the probe and needle and then toward to the screen of the machine. This is the right position between the patient and the machine and the operator. This is the introduction, out of plane, long axis and short axis reminder. This is long axis, out of a plane. This is the short axis, and out of a plane also. This out of a plane. We use out of a plane commonly in the vascular access to central venous line access. You will see the tactile or the tissue movement when the needle insertion from up to down. You see it here and reach to the vessel like a spot, like a white dot. How to identify the solution? You see, sometimes you use normal saline to see the tip of the needle by tissue expansion, like in this demo. You see, level by level, and when you reach our target, we can inject our volume or insert the needle for CV line, for example. Return back to the organ examination. The basic of organ examination. We have short axis view. What mean by short axis view? That mean we put the probe in the cross section of the structure. We need to scan it. For example, we have here vessels or the nerve. We put the probe in the short axis to get the cross section of this structure. This is very common in the nerve block, and in vascular access also use this technique. You will see this structure. Suppose this is the carotid artery, you see it in the cross section, not in longitudinal, while in long axis you will see the longitudinal section of the structure. So there is no cross section. This cross section in the short axis. When you turn the probe to the long axis, you will see elongation, and this is the two wall of the nerve or vessels. So this is a long axis. Like in this structure, this is vascular structure. This is in a long axis approach, while this is in cross section in the short axis approach. Return back to the probe manipulation. We have at least 6 probe manipulation. Start by sliding. What mean by sliding? This is the sliding movement. In sliding movement, we will cover all the circumference of the structure. You see carotid artery here, sliding. This compression, we press the structure in order to visualize the needle, or sometimes used to differentiate between the vein and artery, because the vein is compressible and non-pulsatile. You can see it. This is the compression used mainly in the vascular. When we compress, we decrease the diameter of the structure. In vein, it will be compressed like this. This is the artery, so it's non-compressible. Rocking. There is rock out and rock in. This is the rock out and rock in. Can break the far structure to the mid of screen by this movement. Sometimes to aid to visualize the tip of the needle. You see, by rock out, we can see visualize this area. Tilting, it's important in the visualization of the needle. Sometimes we miss the needle, so use the tilting maneuver in order to see the shaft of the needle or the tip of the needle by tilting. This effect of the tilting to the structure. And we have finally rotation. We change the short axis to the long axis, as you see. This is the rotation maneuver. You can see in the structure, you will see the cross section. With rotation, you can see the longitudinal axis of the structure. Okay. Now in the basic, we have also the organic condition. That means the position. As I mentioned, this is the proper position to put your eyes in the way, the probe and the needle and the screen, while this is the false, this is the wrong. The monitor should be in another side. With our side, as I mentioned, there is eye, needle, screen coordination. Probe handling important also. This is the right handling, while this is the wrong handling. Now we finish the basic of the ultrasound. We have also emergency. In emergency we have fast. For example, go to the fast. There is a 5 position Morrison Bosch, pleural right side, color, and that the comparison. This is the probe. When I take the probe, I compare. This is the probe. You see the screen. This is the window, this is the patient, for example, and I compare with the normal and abnormal. Like in retrovesical. So the ultrasound will learn me when I can put the probe and how I can manipulate the probe and the structure appear, the normal structure appear. This is the vesicle. This bladder, while this is the normal, while this is the abnormal. You can see the collection of the fluid. So I will not go to the details for the emergency because we have feel also for the heart, for apical approach, pulses electrical activity, hypovolemia, ventricle dysfunction, liver embolism, and pericardial effusion. All these found in the pleural examination. It's very important in the ICU or in the theater, how to see the pneumothorax. You see the line, this is the pneumothorax, and you can compare by this window with the normal and abnormal and pleural effusion, how you can see the pleural effusion. It's the right lung, left lung. Okay, return back. I will focus on the regional anesthesia. Now, you see we have axillary block, distal ischius, distal sciatic, and infraclavicular, interscalene, and sciatic nerve in mid-thigh, and lateral cutaneous nerve femoral, intercostal, and obturator, and saphenous nerve, and supraclavicular. So, for axillary, you see this is the colored area, this area of supply. I go to the COE card to see. So, I will learn the steps from the machine. This is the position of the patient exposed. You will see the structures, vessels, artery, and nerve. This structure will be seen. Navigation, how I manipulate my probe for axillary block. After abducted the forearm and arm, and visualize the humerus and axillary artery and veins and the nerves surround. You see the pulsating structure here. This is the axillary artery. It's my landmark here. This is my target now. I go. My needling. This window I will compare with the upper window. For example, when I take my probe here, you see this, for example, and I can see the needling, the axillary artery, the needling, and compare with my block here. There is another tips, and there is a small paragraph contain the steps of the block, the volume you used in the auxiliary block, and the cautions, and many tips. Go to the another block, for example, distal ischius. You see the area of the supply of the sciatic nerve, the medial aspect supplied by the saphenous. The same of the position, in a prone position. Scan the popliteal fossa. Navigation. You see this animation is very good for the beginners to start the original block. After follow the steps made by machine. And my target, this is the sciatic nerve, semitendinosus, biceps femoris, and femoral popliteal vein and artery, and the needling. I will see the sciatic nerve, I see the needle, and I compare in this window with this block, and there's another tips, and this is for infraclavicular, the same. This is for interscalene. For example, interscalene, the position of the patient, the probe. Now how can manipulate? I will follow these steps from the first step by step with the patient. After I see the position, I go to the navigation. I use the probe, in which direction and which vessels or structure should be visualized first. Then go to the target. This is my target. This traffic light appearance of the C5, C6, C7. This is anterior scalenus muscle, middle scalenus muscle, and this is the brachial plexus or the brachial roots. The needling also found. You see the pulsation of the carotid artery, and the needle come from lateral to medial to inject below or surround the cervical root. For example, for this is the lateral cutaneous nerve of the thigh. I go to the anterior superior iliac spine. This is my demo here, and just lateral to the anterior to the sartorius. See anterior superior iliac spine, iliopsoas mundus sartorius. I just locate the sartorius muscle in navigation. It's navigation, and go lateral to see the sartorius muscle. My target. This is the lateral cutaneous nerve, lateral cutaneous femoral nerve, so anterior to the sartorius and the iliopsoas, and in the lateral side this anterior superior iliac spine, and the needle. This my needle should be. Very nice demo. Okay. We have also intercostal nerve, obturator nerve, proximal ischius nerve, sciatic, that means saphenous nerve, supraclavicular and transversus abdominis plane block, TAB block. Go to the TAB block. See the patient position. Locate the costal margin and iliac crest. Go to the navigation to see the three muscles going from the mid to the lateral mid-axillary line, and you can see the three muscles, external, internal, transversus abdominis, and peritoneum. The target, this is transversus abdominis plane, and this is my target. Skin, external, internal oblique, transversus abdominis, my injection here. You can see the needling. The needle come in the plane and inject my local anesthetic here. Another example, for example, supraclavicular block. Also, this is the position and navigation. What I should see, my target, spongiofibrillar subclavian artery. This is the first rib, and this is the pleura. I go to the needling. I compare this window, this is my window, with the patient with this window, and get the proper block. You see the needle. So that's related to the regional block. We have also pain management. I'll go to the pain management, for example, for carpal tunnel. Go to CE card to see the demo. We have median nerve variation, 3 median nerve variation. This one, this 2, this 3. And go to the position of the patient for carpal tunnel. This is the position of the wrist. The scan should be proximal or distal to the median nerve. Navigation. Scan. You will see the slide from the forearm to the wrist to see the continuity of the median nerve here. This is for proximal, this is for distal carpal tunnel, and this needling. This is the median nerve. For example, I go to the knee injection. In knee injection, I have the position just below the under the popliteal or lower thigh. My scan, the navigation. You see quadriceps tendon. You see the femur, and continue under. See the patella. This is the patella, severe. The target of injection. This is the bursa, this quadriceps tendon, fat pad, cartilage, and femur. Inject here. The needling. Very nice. You can see the needle. For frozen shoulder, for example, there is demo for frozen shoulder and shoulder injection. This for shoulder injection. This is ventral and dorsal approach. You can see the needle. This is my window also again, and we compare with this injection, and I can get proper and succeed injection. I'll go for another for pain management, for example, for stellate ganglion injection. You can use by fluoroscope, but now we can use by ultrasound guided. See the position and then navigation to get the cervical ganglion. The target is very clear. Common carotid artery, the stellate ganglion here, and the longus colli muscles. vagus nerve, internal jugular vein, and sternocleidomastoid muscle above. In the fluoroscope, you can see this for stellate ganglion. Let's come to the level of C7. Stellate ganglion very clear, and the injection. This injection below the carotid and in the cervical ganglion, stellate ganglion. So avoid esophagus puncture. I go from the medial to lateral because here the risk of esophagus puncture, I will avoid it by go from the medial to avoid the esophagus and go to the lateral. Suprascapular nerve block. Also the position you see, this is the position of the patient and the scanning from here, from the shoulder tip to the crest of the scapula, the supraspinatus muscle and acromion, and I will be reached to the target. You see supraspinatus muscle and trapezius muscle and this suprascapular nerve and coracoid process. My injection will be here as you see in the needling. This is my window and this is the demo window. The needle come here. So there is ilioinguinal, intercostal, saphenous, stellate ganglion, tap, and greater occipital nerve also involved. Sorry. This is the position of the greater occipital. Navigation between C1 and C2, and you can see it here in fluoroscope view. This is the new technology of ultrasound guided regional anesthesia or pain management, which used for proper and safest procedure, especially for the beginners. PCQ block, we have sometimes missed some nerves after axillary block, or for example for radialis nerve, radial nerve, we have block in the middle arm. This is the middle of the arm. This distal third, upper arm, distal arm, proximal elbow, and lateral elbow joint, and 1 cm distal, and distal elbow 2 cm. This is for radial, also for ulnar nerve and medial nerve. For example, medial nerve. It's for medial nerve. You can see this is in the upper arm and follow the medial nerve with the axillary and it continue as a brachial artery. We have in the upper arm, distal upper arm, proximal elbow, distal forearm. So all the approach it can reach that depend to the site of surgery. So now we have vascular access for central venous line, for example. Scan for internal jugular vein. You see internal jugular vein here. This is the demo. See the internal jugular vein with the brachiocephalic vein. This is the junction with the subclavian vein. Vein location. You can see the distance or circumference. Out of a plane, in a plane technique. This is the internal jugular vein. This is carotid artery. Lumen. See, this is the dot. This is the catheter or the tip of the needle appear pathway. Again, for example, we come for femoral nerve. You see the dot here. I go to the. This is the femoral nerve. Femoral vein, sorry. Access central venous line for the femoral vein. You see the position and the probe will be here. I go to the navigation. This is the navigation. My target. This femoral vein, femoral artery, psoas, and tenous muscle. This is my target here. The needling. After visualize the vein, I go out of the lane. It's preferable for vascular access, and I will see. You see the tactile of the needle until reach to the femoral vein. We reach once the intima of the vein, and you can see the dot inside the vein as the tip of the needle insertion. You see this is the tip. So this is a brief for this machine. We have also epidural and spinal. We can localize the depth of the epidural or subarachnoid before insert the needle, especially for the cesarean section, and that will give a succeed and more safe technique when we visualize the level target anatomy. For example, you see two hyperechoic line. The first hyperechoic line, this is epidural space, and the another, this is the dural matter, this is subarachnoid after it. This is the spinal space, so we have two space. For epidural puncture, after visualize the depth, I can pass my needle with calculated centimeters, and that will be easy. You see, for example, we have here the centimeters of the screen, and can localize the depth for spinal. After localize, I go to with the spinal needle. Very easy. Also, we have general diagnosis. It's not read to us. There is auxiliary. This is the meniscum. This is for teaching. You can see how you can connect the meniscum to the machine and start the position. For example, it's for femoral nerve or vascular access in this area. Navigation and the phantom and target. Femoral artery vein, anterior superior iliac spine. You see it's in the phantom. And this is the screen of the phantom we used. For example, for supraclavicular. There is beep, illuminate, indicate the system is working, and connect to the phantom. And also there is position, navigation, the same of others. This is for all block, for all sides. So we have basic of the ultrasound machine and the probe and needle and the planes. We have emergency for lung, pleural, feel for heart, fast technique. We have epidural and spinal. We have phantom, musculoskeletal injection, knee, carpal, suprascapular, pain management, stellate ganglion, paravertebral block, for example. This for paravertebral block. Very great anatomy by 3D animation. See the position, we have two position. This is the position of the patient. See the probe. Okay. You see the navigation one. What we will see, transverse process and the pleura, and you see the paravertebral space very clear. For example, this is the target, our target and paravertebral block, transverse process, and you can see costotransverse ligament, and you see paravertebral space, and you see the pleura below. Okay, after primary regional anesthesia, all the block you can see, and the CQ blocks and vascular access. This is for procedure. Okay, we have also image, how you can accommodate your image. This is for gain, near gain, far gain, and the frequency, size of orientation. This is for gain and the quality. Okay, you can. This is the patient record. You can record any procedure, and this is record for 30 minutes. Okay, also this transfers for memory stick, USB stick. Okay, we have also treasure measurement, annotate and measurement. This measurement for the vascular or for Doppler also. And utilities, this is for the language, for screen, for maintenance. We have upgrade system. We can update any procedure or any new software from via internet. Take the link by the memory stick and insert to the machine, and I can update it or upgrade it all the system. And now let's see the icons. You see, this is the B mode, this is the C mode of the Doppler. Also you can see the M mode. This is a mode found in the screen. It's motion mode. And this for pause. If we want to take a picture or take a measurement to the structure, this is the picture and this recording. Okay, this turn on, turn off, and we have also on the side I can change my probe. Just open this block and put curvilinear probe, for example, and close it. I will change the picture like this. You see, I can manipulate also the contrast by touch. By touch I can manipulate the contrast, and also the depth by the contrast, by touch. You see, I change the depth by touch as I need. This is the battery charge monitor, and this is turn on, turn off, and this is the alarming of the battery charging. Okay, that's okay.